take my chest drain and remove the trocar. I'm going to use the end of my clamp to pick up the tip of the chest drain. I'm then going to slide my finger out as I slide my chest drain in through into the pleura, into the pleural space. I'm going to release the end of the drain and advance the drain up for pneumothorax or down for a hemothorax or a pleural effusion. And I'm going to advance it to the midway between the two black markings. Whilst I'm waiting to secure the chest drain, I can either clamp the tip of it, or I can connect it to my underwater drain. But at this point I need a second pair of hands to give me some assistance just to support the end of the drain. I'm then going to suture the drain in place with a thick silk suture. You then continue wrapping the suture around and tying it tightly so it pinches the edge of the drain to secure the chest drain in position. And continue up the drain until the end of the suture. So the chest drain is connected to an underwater seal system, which comprises of a bottle and a connecting tube. The bottle needs to be filled to the mark with sterile water. So the connecting tube goes into the bottle and then screws on. And then there are two tubes, one to connect to your drain, the bung comes off, and then an open port to air, or that could be attached to suction. So having secured the drain, you then connect it to your underwater seal, which you filled earlier. And you should see the tube steaming, some steam in the tube, and it bubbling with inspiration and expiration.
As with any procedure, having completed the chest drain, it is now important to go back and reassess your patient, in particular their airway, breathing and circulation. If the patient is stable, now order a chest X-ray to confirm the position of the chest drain. Again, as with all procedures, you must document the procedure clearly in the notes. Your documentation should include the size and position of the chest drain, any complications that may have arisen during placing the chest drain, and the results of the chest drain placement, for example, fluid that may have come from the chest cavity, quantity, colour and consistency. If the chest drain was placed for a pneumothorax, it is important to document that the tube is fogging with expiration and that the chest drain is swinging appropriately. Finally, for both the OSCE examination and for real life, it is important to know the lists of early and late complications that can arise after a chest drain is placed that are documented in the ATLS manual.